Now, what is very important is that heart failure is a deadly disease. There is no doubt about it. If you compare heart failure with the various cancers that we have, you can clearly see that heart failure is right on top. It has a 48% 5-year death rate, which is right on top. That means after every 5 years, you will lose half your patients. And this is very important data from the National Cancer Institute surveillance. We have to know that heart failure is a progressive condition with a high mortality. So as you go down time and have repeated heart failure admissions, so also is the death going to really increase. For every admission, there is going to be an added mortality and also a decrease in the function of quality of life. So every admission is a point by which we should look at these patients more carefully and make sure the patient is covered completely, not only by the GDMT, which is guideline-directed medical therapy, but all aspects of the patient should be taken care of, including his heart rate, including his iron levels, including his nutrition. Now, if you look at patients with heart failure, 9 out of 10 patients, despite being on good therapy, are symptomatic, which is a big number. Nearly 1/3 of all heart failure patients are at high risk of hospitalization or cardiovascular death, including those who are even stable. So even in patients who are stable, 1/3 of them will suddenly deteriorate without any warning. What is important, and I said this before, is that every hospitalization is associated with a decreased lifespan from the first hospitalization of around 2.5 years and the final hospitalization of less than 1 year. Death is inevitable after each hospitalization. Compared to the Western population. Now, if you look at the Western population, the average age of these patients is 73 years, the hospital mortality is around 4%, and the discharge mortality at the end of 6 months is 8%. But in India, things are a little different. The average age is much lower. It's almost 20 years lower at 53 years of age. The mortality is 30%, which is 10 times that of the Western world. And the post-discharge mortality at 6 months is again about 4 times the mortality of the Western world. So we can conclude by saying that heart failure in India, patients get affected at a much younger age. They have a very high in-hospital mortality, and also they have a very high 6 months mortality. Now, if you look at the inter-study, you can clearly see here that about 20% or 1/5 of our patients, 1 in 5 patients will die within a year of diagnosis, and 2 or 3 patients out of 5 will die after 5 years. The highest mortality is seen in Indians and African patients. So patients are at a very, very high risk of cardiac death. And as I showed you before, it's much worse than any other cancer that is treatable as of now. Now, what is the load of the problem in India? 10 million patients of heart failure in India. 1% of all adults have heart failure, which is a huge number. Post-admission, mortality is up to 30%. Less than 50% of patients take medications carefully. Actually, the number is actually more towards 25%. The population is very young who get heart failure, around 50s compared to 70s in the Western world. Diabetes is highly prevalent in heart failure as per the Trivandrum Heart Disease Registry, and even hypertension is also extremely prevalent. It is safe to say that coronary artery disease risk factors of diabetes and hypertension are one of the chief driving forces of heart failure in our country. Now, if you look at our own data, the Trivandrum Heart Failure Registry, you can see that 3 out of every 5 patients that died during 5 years of follow-up had an approximate age of around 3 years in heart failure before they died. Lack of GDMT in patients and also frequent admissions are 2 of the biggest risk factors for having a higher 5-year mortality. 1/4 of patients who are discharged on GDMT are associated with a much lower 5-year rate in heart failure. Anything that will increase the GDMT will improve heart failure outcomes in India. So we realize decreasing hospitalization and taking drugs which improve survival are the two ways that we can deal with the problem. So the goals of therapy in heart failure is number one, to increase survival. And increasing survival is to reduce premature mortality by either of the two modes, either pump failure or sudden cardiac death, which is because of arrhythmias. And this is where the drugs like beta blockers and ARNI become very important. Reducing hospital admissions is very, very important because we realize that every hospital admission increases the mortality of these patients. Hospitalization is a time-consuming activity for the patient and the relative, and it is very costly. Anywhere between 30 to 50,000 is the admission cost of patients in a metro city. The third goal is to make people feel better, to improve symptoms, quality of life, and slow down the rate of deterioration, and allow patients to remain out of the hospital. And how was the journey of randomized controlled trials in heart failure? Well, there was not much happening from 1986 to 2000. Almost 14 years, we had a couple of studies, not too many, but there were important starts to this. And the first important one was the hydrazine isosorbide dinitrate. And this seems to work very well in our patients, especially those who have recurrent hyperkalemia or increasing creatinine levels. ACE inhibitors dominated the 1990s with the Valheft consensus solved in the solved T trial. And there was nothing happening till the late 90s when beta blockers started appearing. And by the late 90s, beta blockers then took up the stage from ACE inhibitors. And with the USCP, the MERIT and CIBIS and the Copernicus trial, they were all beta blockers out there for heart failure. And that really changed the scenario for heart failure mortality. There was a brief appearance of MRAs by the turn of the millennium with the RAL study. And again, this allowed us to use spironolactone in this patient. Well, things changed dramatically when we entered the new millennium. And from the 21st century onwards, you could clearly see here that the whole randomized controlled trial exploded in the form of multiple new drugs, beta blockers, ARNI, MRAs, isoleucine dinitrate, ARBs, ivermectin. Device therapy came in a big way from 2004 to 2010 and was very responsible for decreasing the mortality. And towards the end of 2012-13, the SGLT2 started making their way into the scenario along with ARNI. And that has really shaken up the market and improved mortality and hospitalization. So the paradigm HF trial, which came in at the end of the 2010-12 period, really heralded the first of its kind drug, a drug which was never seen before, a drug which combined two interesting molecules of sacubitril and ARB together in comparison with the industry standard, which was enalapril, looking at cardiovascular mortality and heart failure hospitalization over a 2-year period. The inclusion period was all HFrEF patients who were stable on an ACE or ARB. Elevated BNPs had to be there, and patients had to have an EF of less than 35%, and they had to be symptomatic. You had to have a fairly normal creatinine and no hyperkalemia. This was the largest mortality and morbidity trial in patients with HFrEF, and also was the most racially diverse trial with HFrEF. Now, what did it show? Once looking at the cardiovascular death, the heart failure hospitalization, overall mortality, there was anywhere between a 16 to 20% benefit when you took the combination of sacubitril with ARB compared to enalapril alone. And what was most important was the heart failure death came down by 20%, and sudden death, which is also an important parameter to look at heart failure, also came down. And this was on patients who were already having ICDs to start with. So the 4 drugs, that is ACE or ARBs, beta blockers, aldactone antagonists, and hydrazine nitrate, caused a significant reduction in mortality from anywhere from 17 to 43%. There was a significant reduction in heart failure hospitalizations from 30 to 33%. And also the numbers to treat for mortality reduction really came down to single digits. And that set the stage of a very, very good, robust medical therapy. And ARNI came at this time when things were already looking good and really shook the stage and caused a significant mortality reduction of 20% and a significant hospitalization of 21%. And this was over and above good heart failure treatment. That means patients were on aldosterone antagonists, they were on beta blocker, they were stable on ACE or ARBs, and they were on hydrogen nitrate. So over and above this very good benefit that we've been seeing, ARNI added to that benefit by almost 20%. Now, what is also important is that the patient's quality of life started improving. After 30 days of treatment with sacubitril valsartan, almost a third of the patients you can see here started improving towards the stage above. So stage 4 patients started moving to stage 2, and stage 2 patients, class 2 patients started moving to class 1, you can see after 1 month. So there was a definite improvement in the quality of life. Now, when you look at ARNI versus the industry standard, which was ACE inhibitor, whether you looked at age, whether you looked at ejection fraction, whether you looked at eGFR, whether you looked at systolic blood pressure or NT-proBNP, at every parameter, the sacubitril group did better than the enalapril group at all stages. And if you look at the overall clinical efficacy, Asians did quite well. There was a good representation of Asians in the trial, and whether it was a primary composite outcome of CV death with hospitalization or the independent MACE parameters of CV death and heart failure hospitalization, and also all-cause death, Asians generally did better when they were on sacubitril valsartan. So what is important is the illusion of stability in heart failure, the so-called illusion of asymptomatic patients. We do know from data that 20% or 1 out of 5 patients who is so-called stable, no prior heart failure hospitalization, already had a primary event. 17% of patients died during the course of the trial. And out of the stable patients who experienced a primary event, death preceded heart failure hospitalization in almost 50%. 60% of these deaths were sudden cardiac deaths. So the illusion of stability, we have to be able to identify and realize that just because someone didn't have a prior hospitalization doesn't mean he's going to be stable forever. These are the patients who have a high risk of sudden cardiac death and also pump failure. So therefore, ARNI should not be delayed and should be started as early as possible. It is important to note here that you need a 36-hour washout period when the patient is on ACE inhibitors before you start ARNI. So the American College has given these very strong recommendations for ARNI. And what they say is that in patients with HFrEF who are symptomatic, there has to be the use of ARNI to reduce morbidity and mortality, and that gets a class 1A recommendation. In patients who cannot use ARNI for whatever reasons, like angioedema or non-availability or cost, only then ACE inhibitors should be, and ACE inhibitors also are good drugs with the 1A recommendation. In those patients who cannot use ACE or they cannot use ARNI because of angioedema specifically, only then the ARBs can be used to decrease morbidity and mortality. And what is also important is that the use of ARNI has a high value in terms of economics as well. Even that statement has come into the guidelines. Now, is acute decompensated heart failure different from de novo heart failure? Now, if you look at acute decompensated heart failure, these are patients who already have the substrate of heart failure. They've had admissions before, they've had LV dysfunction evaluated before, whereas de novo heart failures have no other history. There are a lot of comorbs in patients with acute ADHF patients, where it is less frequent in de novo patients. The trigger events are mostly the medication, the compliance, infections, intercurrent infections, diet, excess salt, so on and so forth, and drugs. Whereas here, de novo heart failures, it most probably is etiological. Either it's an ischemic cause, it's inflammatory, could be COVID, or could be toxic. The clinical presentation is usually insidious in decompensated heart failure, while it is quite catastrophic and acute in de novo heart failure. The main pathology obviously here is the maladaptive neurohormonal state with a fluid excess, salt excess, and redistribution. Here it is primarily a LV pump failure in de novo heart failure. Cautions we need to take. Now, the Pioneer heart failure study looked at it with around 800 odd patients, and they looked at patients primarily admitted with ADHF with an EF of less than 40. These patients, while stabilized, had a blood pressure of more than 100. They did not have any increase in IV diuretics. There was no IV vasodilators. There were no IV inotropes in the last 6 to 24 hours. This is the group that was taken for the Pioneer heart failure study. That means they were stable, they did not go into cardiogenic shock, and they were not in a recurrent or bad pulmonary edema. And then they looked at these patients on the sacubitril versus the enalapril arm, and this was taken over 8 weeks, and this is what they studied. Those patients on sacubitril valsartan had a significant decrease in the NT-proBNP. We must also remember not to use BNP because it would anyway be altered because sacubitril valsartan acts on the BNP by itself. So we need to use NT-proBNP whenever we have patients with sacubitril valsartan. So there was a 29% reduction in the NT-proBNP, which you know is a marker of heart failure, and there was almost a 42% reduction of cardiovascular death or hospitalization for heart failure. And these changes happened pretty early. By the 4th week or so, patients started displaying those benefits. Now, if you look at the breakdown of patients who were actually having worsening versus those who were de novo, most of the patients were patients who were on the ACE or ARBs already had LV dysfunction. And a good chunk was on ACE inhibitors without ARBs, and very few were actually de novo patients. Now, if you look at the change in the NT-proBNP, you can clearly see that whether you had a de novo patient, fresh patient, whether you had a worsening chronic heart failure, whether you had ARB and no ACE inhibitor, or whether you had no ARB and an ACE inhibitor, at every kind of patient, the decrease with the sacubitril valsartan arm was much more pronounced by a significant margin of 20% compared to the patients who were already on the drugs. So therefore, if we were to look at it in a more holistic manner, these are all the patients who should have got ARNI from the word go, rather than trying an ACE-ARB and then getting into trouble and then restarting an ARNI. So this clearly shows that early ARNI treatment and early substitution of ACE-ARB to ARNI is the way to go for the future. Now, the patients who did not have an ACE or ARB, you can see still benefited from the sacubitril valsartan arm. There was a significant 28% reduction, and also you're getting a very robust 48% reduction with the ARNI compared to enalapril in these patients who were not on prior exposure to ACE-ARBs. At the same time, we must also see that both the lines diverge very early, and you're getting some very early benefits within the first 2 weeks. Now, the global report heart failure registry showed that 43% of the overall patients who were de novo were from the North American and Southeast Asia. So Southeast Asia and North America given a lot of the trials. And 66% of patients in the prevalent study also were newly diagnosed HFrEF. So in a patient with a de novo HFrEF or a new onset heart failure, you can clearly see that sacubitril does wonders. There is a significant reduction compared to ACE inhibitor, even in the freshly diagnosed heart failure patients. There is a significantly lower incidence of composite of CV and heart failure hospitalization in patients who were put on sacubitril valsartan. Now, when you start sacubitril/valsartan immediately after the patient gets admitted, and this was seen in the transition study, this clearly shows that the initiation of sacubitril/valsartan in these patients had significant remodeling or reversing of the adverse remodeling and pump function month better than the patients with ACE or ARB in the de novo heart failure patients. Also, the troponin Ts, which is a marker of inflammation and ischemia, also came down with the sacubitril/valsartan compared to the ACE inhibitor patients by a significant margin. Now, when you look at the heart failure with reduced ejection fraction, the primary endpoints, and the patients who had any kind of permanent disclosure, you could clearly see that the patients on the sacubitril/valsartan arm, whether you had a de novo heart failure or you had a patient with a prior heart failure, both had significant benefit on the sacubitril group, and their heart failure admissions were much less. So what we learned from the transition study is that the first-line initiation of sacubitril/valsartan in de novo heart failure patients, alongside the initiation of other guideline-directed therapies, is feasible, it's safe, and you get a better risk-benefit profile than in patients with a prior HF study, that is prior LV dysfunction and then coming with worsening. Early intervention with sacubitril/valsartan should be considered to delay disease progression and should possibly be the first drug that you start in a de novo heart failure patients. Now, the update to the 2017 American College guideline, this was the 2021 guideline, clearly showed that in heart failure with reduced ejection fraction stage C, that means patients with LV dysfunction less than 40 who had clinical features of heart failure, the first important diagnostic algorithm involved the initiation of either ARNI, ACE, and ARB, and they went very strongly compared to 2017, where they said that ARNI could be given, and here they changed the tone and said ARNI is a preferred drug in this situation and should be the first choice of drug along with beta blocker and diuretics. So therefore, with this transition from 17 to 21, we have ARNI, which is no longer one of the choices, but here ARNI is the preferred choice in newly diagnosed heart failure patients. And then it goes on to talk about the various other scenarios of heart failure, the volume overload, the GFR problem, the potassium issue, patients who belong to the black race or do not respond to the ASR, the use of hydrolysine, and also patients in sinus rhythm with a more than 70 heart rate needed IVBT. So it's very, very important to start well, to start with an ARNI, and then all the other drugs, foundation drugs, can be initiated. What is also important is the first 4 weeks should be used to get in all the 4 foundational therapies, that is the ARNI, the beta blocker, the SGLT2 inhibitor, and the MRA, along with the diuretics, of course. Small doses of all 4 foundation drugs should be initiated in the first 4 weeks to get the best benefit, because we have seen the data that the first 4 weeks are very treacherous and there's a very high mortality for these patients. And then over the next 6 months, we need to build upon their doses. The European Society on the other side of the Atlantic again gave a very strong recommendation for ARNI, and they say that it is a first-line therapy for heart failure with reduced ejection fraction rather than an ACE inhibitor. So you don't start ACE/ARB and then transition. You need to start straight away. So initiating drug is ARNI, and the European Society gave that very strong recommendation. And again, as I said again, we've talked about this, that the American College again stressed that ARNI is a first choice drug, very strong recommendation, and only look at an ASR when ARNI is not feasible for any reason. So very important when we start a ARNI you want to make sure that if the patient is on ACE, ensure 36 hours washout period. Now, the dosage of statin is based on what the clinician feels. It is based on the blood pressure. But if the patient is on less than 10 milligram of enalapril or less than 160 milligram of valsartan, we like to start with a small dose of 24-26 milligrams twice daily. If the dose is higher than 10 milligrams of enalapril or more than 160, then we would straight away jump to the 50 milligram dose twice daily. And we know that the 25 milligram dose twice daily can be achieved by splitting the tablet into two, and most of the ARNI tablets are scored, so that's a very good thing. After a period of 2 weeks, you assess the tolerability, and maybe after 4 weeks, then you would jump the dose from 50 twice a day to 100 twice a day, and that would be the real trial drug figure to achieve the ideal dose. But during this time, over the next 4 weeks, 0 to 4 weeks, blood pressure, electrolytes, renal function should be checked very carefully. Now, when ARNI is not possible for some reason, then ACE and ARBs could be started. And every 2 weeks, you should increase the dose of ACE and ARBs till the maximal tolerated drug dose can be achieved. And the same precautions with ARB has to be taken care of, the blood pressure, renal functions, and potassium. Now, beta blockers have to be started very slow because there is a chance of worsening the LVF, the cardiogenic failure. So they have to be started very slow, slowly titrated again over every 2 weeks. Weight is a good thing to watch for, heart rate is a good thing to watch for, and blood pressure as well. If the patient is going back into congestion, it's worth stopping and decreasing the dose till the patient achieves a stable period. During the initial period, good dose of diuretic should accompany beta blockers, and then they should be slowly weaned off. Now, some of the reasons of intolerance of sacubitril valsartan is worsening kidney failure, which is important, hyperkalemia, gastro symptoms, and symptomatic hypertension. We're not worried about hypotension as such, because even with 90/60, you can actually start the drug, provided it's done carefully and the patient is fluid-free. But if a patient is symptomatic with hypertension, having dizziness, weakness, do not start the drug, or you need to stop the drug. Now, the reasons for failing to achieve target dose, again, is basically based on the same problems of worsening kidney function. Hypotension is the biggest problem with ARNI, and therefore you have to be very careful in uptitrating the dose very carefully, making sure that the diuretic doses are gradually weaned off, because ARNI also acts like diuretic and there can be fairly significant hypovolemia. Now, if you look at the dose benefit ratio, at every dose, 50%, more than 50, 100%, there is a benefit over and above enalapril. And overall, there is a 20% benefit overall compared to enalapril at any dose. So while we are interested in getting to the target dose because the max clinical benefits are there, any dose of sacubitril has a better benefit and a lower risk than patients who are taking enalapril. So while we're interested to reach the target dose, any dose, small dose or initiated dose is really worth the effort, because you get that even good tiny benefit. What about patients with borderline systolic blood pressure? So if you look at the data, this is European data, and you can clearly see that there is a significant decrease in the event rate of almost 12% at every level of blood pressure, at the lower levels of blood pressure, as well as at the higher levels of blood pressure. You get a very good 12 to 14% reduction and an overall almost 20% benefit irrespective of the blood pressure. So when you look at hypotension and death, you can see that both the drugs are equal actually, and the hypotensive episodes are there with both. And actually, if you look at it, it is actually lower in the sacubitril valsartan group. What is very important to understand is patient should be fluid replete before we start sacubitril valsartan. And we need to start at the lowest dose. We need to make sure hypovolemia is corrected. We need to make sure the sodium is all right. We need to make sure that the patient is on adequate salt and not completely salt deprived before we start the drug. We need to understand that sacubitril valsartan has its own intrinsic diuretic capacity. So therefore, the high dose diuretics which have started on day one have to slowly come down. They need to be down titrated. Otherwise, you're going to get a significant hypovolemia. We need to take into account elderly patients, fragile patients, patients with orthostatic hypotension, and start them on very, very mini doses of 25 milligrams of sacubitril twice a day, and maybe start with even 125 milligram, preferably at nighttime, where the effects of postural hypertension is the least. Patients who are not on ACE or ARBs and they come to us with heart failure de novo, they deserve a much lower dose of sacubitril and a slower titration. Any other drugs that are on the patient which are also causing low blood pressure need to be looked at carefully and sometimes even omitted, because we know that ARNI has a huge advantage over the other drugs. And we have to be clear at the end of the day that every patient cannot reach trial doses. What is important is that heart failure is a team management, and I would rather have the patient only on 50 milligrams of sacubitril, but patient also having an SGLT2, also having a beta blocker and an MRI. So all 4 drugs together over 4 weeks is much better than one drug at a high dose. And there was a very nice article which was looking at whether ARNI is going to decrease the device therapy. So we do know that device therapy is a class 1 indication according to the American College, a very strong recommendation. And we know that whether you have a ischemic etiology or a non-ischemic etiology, the recommendation for ICD is very, very strong. It is in patients who are symptomatic, it's in patients with the EF less than 35, and it's patients who you've given good 3 months of therapy and they have a good functional status, and those are the patients who get the devices. Now, if you have a patient who's on OMT, which would obviously also include ARNI, and if the patient is on ACE, you need to replace with ARNI. He's symptomatic and he has an EF less than 35, and you've had at least 3 months of OMT, ICD is the way to go. If you have a patient who is symptomatic with a wide QRS of 120 to 150, then a CRT-D is the way to go. If the patient has a fairly end-stage heart failure and on MRI, you don't have a significant scar, especially seen in the non-ischemic dilated cardiomyopathy patients, then a CRT-P is a good thing to give because it costs substantially less. So in patients, we know in CRTs, there are almost 1/3 of them are non-responders. So these are the patients we believe will actually benefit with ARNI use because the EFs will improve, adverse cardiac remodeling will be prevented, and VPCs come down and you have the biventricular pacing actually optimized. And this is data from the Trivandrum Heart Failure Registry. 55% of patients who were hospitalized for heart failure had diabetes. Now, if you look at the patients who were dying, a good number of them had suboptimal drugs at hospitalization compared to patients who were on good GDMT. And the same was true at the time of discharge. The mortality significantly went up in patients who were not on optimally guideline-based therapy. Now, if you look at the diabetes prevalence in all the big heart failure data right from the 1990s, the average percentage of diabetes is around 30%, or 1 in 3 patients had diabetes to start with. And if you look at the prevalence of heart failure in diabetic trials, and these are trials on diabetic drugs like the GLP drugs, the SGLT2 drugs and the DPP-4 drugs, about a third or 30% of them approximately were again having heart failure. So we believe that diabetes and heart failure are very closely linked, and approximately anywhere between 30% of heart failure patients have diabetes, and up to 30% of diabetic patients have a mild to moderate heart failure. Now, the data from the Paradigm HF clearly showed that whether you are diabetic or whether you did not have diabetic, the hospitalization and cardiovascular death benefit was there for all. It was a little higher for the patients who were non-diabetic, but even if you're diabetic, you got away with a very good 20 to 22% reduction in hospitalization and CV death. If you look at the glycemic control, you will see that the addition of sacubitril gave you better glycemic control over a 3-year period compared to enalapril. The use of insulin also came down by almost 30% in the ARNI patients in blue compared to enalapril. And new onset use of OHAs was also much less in the ARNI group. The cardiometabolic modulation that ARNI does seems to put it very favorably with diabetic patients. And since a large percentage of heart failure have diabetes, and diabetes having heart failure, we feel ARNI is a drug which is clearly at a huge advantage in this population. Now, what about with HFpEF? We know that HFpEF is a completely different entity compared to HFrEF. We don't know enough about HFpEF, but all we know is that patients have congestive symptoms, they have elevated BNP, and they behave very similar to HFrEF in terms of morbidity and mortality. We do know that HFpEF is mainly caused because of conditions outside the heart, while HFrEF is primarily a myocardial abnormality, a pump failure with the resulting damage elsewhere. So HFpEF, we know, has been looked at in the CHARM study, the iPreserve study, the PEP-CHF, and the TOPCAT study, and most of the drugs were clearly not having a major benefit. Now, if you look at the HFpEF and HFrEF, survival curves are very, very similar. So whether you had an EF of more than 50 or an EF of less than 40, your mortality seems to be fairly similar. Now, although the ARNI trials with HFpEF have not been very robust, but what can be clearly seen is that even in the HFpEF place, the reduction in NT-proBNP, which we know is a valuable marker, is much better, almost by 23% reduction compared to valsartan alone. LA size reduction, again, is much better compared to the ARB. Your improvement in NYHA class is much better with the sacubitril at the start, as well as towards the start of the trial, and definitely towards the ending of the trial. So we can speculate that although the sacubitril versus valsartan trial, Paragon heart failure trial, was sort of equivocal, and the numbers really did not prove to be significant, we know that there was a definite trend towards decreased hospitalizations and decreased cardiovascular trend. There was a trend, although not significant. And one of the reasons that we would believe is that valsartan also, as a component of sacubitril, has a very powerful benefit in this population. So whether you are, the sex differences, again, were a little more revealing in that females and patients who had a lower EF, they're the ones who actually had a better benefit with the sacubitril compared to those who had near good ejection fractions and who were males. And if you look at the EFs, the ones less than 50 are the ones which clearly had the benefit compared to the ones above 60, clearly showing that anything less than 57%, you did get a benefit with the EF. If you look at the deaths and the heart failure population also, we can clearly see that as long as the EF was less than 50, you got a real benefit of both mortality and hospitalization. But as your EF improved above 50 and went towards 60, then whether you were on an ARP or an ARNI did not matter. We know that the data has clearly said above 57, there is really no benefit, but there's an emerging trend of benefit above 40 and less than 57%. And clearly here, the guidelines, the American College has given the guidelines. They are not very prominent guidelines. They're not very strong guidelines like the guidelines for diuretics or even SGLT2, which has a better recommendation of a 2A with the HFpEF. But ARNI still comes in a close third, and there's a 2B recommendation that if you have a patient who has heart failure, elevated NT-proBNP, and an EF of less than 57, ARNI still can help you. And now there is the FDA indication also that has come up. So here, any kind of angioedema, hypotension, worsening kidney failure, or hypotension is a definite contraindication to ARNI. But it is also been seen that the level of rise of potassium is much lower in ARNI compared to enalapril. And what it also does show that when you start these patients initially with ARNI and then start MRAs, their hyperkalemia associated with MRA was much lower. When you look at the clear contraindication is never start an ARNI within 36 hours of ACE. Any history of angioedema should be avoided. Pregnancy, lactation should not be used. Child puke score C, again, cannot use. If the patient is also on alscarin, do not use it. And if the patient has a hypersensitivity to either ARB or ACE, please don't use it. Now, the caution to use it is you need to have a GFR of preferably more than 30. It's better to avoid initiating at a GFR less than 30. At a GFR of more than 50, then you need to make sure that you can start with the lowest dose and then go up. In a moderate child puke B score, again, you need to start half the dose, that is 25 milligrams twice daily. But in the puke A score, there is no reason to have any kind of drug adjustment. Renal artery stenosis is again a relative contraindication. Blood pressure less than 100 symptomatic, again, is a contraindication. And obviously anybody with a volume depletion. Drug interactions, it cannot be given with ACE, cannot be given with alscarin, should not be given potassium sparing diuretics, cannot be used with NSAIDs, lithium, or birth control pills. So strict low potassium diet, the loner salt that we tell our patients with heart failure to use should not be used. They need to have a normal sodium salt, not potassium supplemented. Loop diuretics have to come down in these patients. You can go with K-bind in emergency situations along with a saline nebulizer. And as a first dose in the hospital, if once the IV line is in, I think glucose insulin infusions can be started. Insulin glucose infusion can be started, and they really bring the potassium down. Patiromer is a new potassium binding drug. It will be a boon. It's going to be available possibly sometime next year. And this is data from a prospective registry of around 400 odd patients over 7 months, and clearly showed that if you withdraw the ARNI in patients after they reach their targets, there is an independent all-cause mortality which actually increases, as you can see here, by almost 13 times compared to patients who are on the ARNI and not removed. So major increase in all-cause mortality. There's a decrease in functional class, decrease in ejection fraction if you suddenly decrease these drugs. Now we do know that the benefit of ARNI is there up to 57%. So it is very important that till you get there, please don't stop the drug. So whether you're in a HFrEF space and you actually move up to the HFmRF space, which is anywhere between less than 40, more than 40 and less than 50, or if you're in the HFpEF place where your EF is less than 57%, then you should consider allowing the patient to take the drug. So even in patients who reach the HFpEF, that is, they reach 50% after treatment, we must continue the GDMT to prevent relapse of heart failure. So, ladies and gentlemen, to conclude this very interesting monologue on ARNI and heart failure, we are very happy to know that ARNI is the molecule of the century. It gave us a 20% benefit despite patient being on good heart failure drugs, which you know as ACE, R, beta blockers, and MRAs. It is clearly superior to ACE in reducing CV death, heart failure hospitalization, and sudden cardiac death. It improves LVEF and heart failure. It reverses the adverse remodeling and improves the QOL in both HFrEF and HFpEF. So it is very important to start ARNI early in the de novo heart failure patient and in the patient who's come with worsening heart failure, even if he's on good doses of ACE inhibitor. We believe that the earlier you start, you gain life years. ARNI should be given for at least 3 to 6 months along with the other 3 foundation drugs of SGLT2, beta blocker, and MRAs. The EF has to be assessed every 3 to 6 months, and you can continue this drug up to an EF of 57, and it is good to keep the drug on because early removal of the drug after each target has been known to cause worsening heart failure and death as well. Even in patients with HFpEF, up to a EF of 57, you can give this drug provided all your criteria for HFpEF are being fulfilled. And in this population, it has been shown that despite there not being a significant reduction, there is a reduction of heart failure hospitalization and an improvement in quality of life. Thank you very much for your patient listening and hope you had an enjoyable time listening to this presentation on ARNI. Thank you.